Hi, hello everyone, and welcome to the second session of the Center for Health Informatics virtual speaker series. I'm Caitlin Corkin, as lots of you may know, and I will be the moderator for this event. I'm very excited for today's presentation as we will be highlighting the remarkable work done by our wonderful team here at the CHI in relation to the COVID-19 pandemic. I will kick things off by introducing our two speakers for the afternoon, Frank Lee and David Vickers. Frank is a member of the Center for Health Informatics, the Data Intelligence for Health Lab, and is a PhD candidate in Epidemiology in the Department of Community Health Sciences at the University of Calgary. He has also completed a Master's of Public Health at the University of California, Berkeley. David Vickers has a PhD applying dynamical systems theory to epidemiology. Before joining the Libin Cardiovascular Institute in October 2019, he worked as a research associate in the Division of Immunology at the Imperial College London. Together, they will showcase how the team at the CHI tackled the COVID-19 pandemic with data and modeling. Since the beginning of the pandemic back in March, emergency responses surrounding COVID-19 have moved very rapidly. The World Health Organization declared COVID-19 a public health emergency of international concern on January 30th, 2020. It subsequently followed with a pandemic declaration on March 11th. The CHI team quickly mobilized to face this tremendous challenge. With the guidance of the U of C COVID-19 task force, our team started working collaboratively with the province of Alberta and the city of Calgary in partnership with Alberta Health Services and Alberta Health. This talk will focus on the COVID-19 modeling projects that CHI was a part of, the different research questions addressed, and the lessons learned about COVID-19. Without further ado, I'd like to welcome Frank and David.
Thanks, Caitlin. So when Tyler approached David and I to do this particular presentation, the three of us got together and then we're just talking. And David actually mentioned, today is actually 111 days since the first case of COVID-19 was detected in Alberta, which was March 5th of 2020. So we decided to play on that a little bit and call this presentation 111 days later. A lot has happened since then for CHI. I'm sure many of you in the audience are aware that Tyler did a talk about the whole COVID tracker. There's even a video done by OIPH featuring one of our software engineer, Alex, on it. But David and I like to emphasize that this particular talk is not about the COVID tracker. It's more about modeling analytics and the science of data surrounding that particular issue. And before we jump into the actual presentation, we would definitely like to acknowledge these wonderful following individuals that have made tremendous effort in many of our projects. No, David and I are not the only ones that's been crunching the numbers behind the scenes. And so we have teams from Center for Health Informatics, Cummings School of Medicine, and external collaborators. So again, these individuals, very tremendous recognition is deserved to them as well. Just to give you a brief overview of our talk today. So the way we're gonna start it off is just describing a little bit of history and what we've been up to. Then our real main purpose is to discuss two modeling projects today. But what we want the audience is not to just get an understanding of what we've been up to, but also get a sense of what have we learned? How can we take what these guys have done and sort of apply it to our own experience, or apply to your own experiences? And then we'll end up with some of the lessons learned from this whole modeling process. So I'm sure at this point by now, everyone is sick and tired of hearing COVID-19. Yes, it has made a huge impact on our lives. And for Alberta, the first case was detected on March 5th. And within the next couple weeks, 2 to 3 weeks, things in Alberta escalated pretty quickly. And I'm sure everyone is familiar with the specifics around it. So CHI began our sort of the analytic activities on March 14th. I still recall that was a Saturday when that email from Tyler was sent out. And one of the things that became very clear to us was everyone was looking for questions. Everyone's looking for answers to the questions that there was no answers to. So realistically, we needed some form of analytic solution. And this came not just from the university administration. This kind of, questions, requests came from provincial governments, the city of Calgary, and their agencies. And when we are dealing with a pandemic or outbreaks like situation, most oftentimes what we need to know for or provide for decision makers and the policymakers is that they need an information on where we are headed with this outbreak or pandemic. Without that information, they will not be able to make any decisions in the process. And from analytics standpoint of view, in order to provide directions on where this thing is headed, you have to triangulate by applying multiple methodologies and just to really get a sense of where we are headed. And once that information can be then moved forward to those people needed to make a appropriate decision. And one solution to this is really the whole modeling approach of the infectious diseases. This field has been in, the whole concepts have been established since 1950s, but it is in this pandemic that, this really became a focal point of our talk. So before we jump into some of the discussion about the projects, a couple of things that we would like to remind the individuals is that these infectious disease models, they are not the perfect descriptions of reality. Most oftentimes, these models are simplified versions of reality where there are specific assumptions made. And oftentimes, these assumptions will drive the behavior of the model itself. Not only that, these models are not dependent upon what we call the perfect or complete data. Depending on the research question that you are designing to answer or using the modeling process, there will be specific data elements that you're looking for, but that data is not available, or if you're thinking of, or if you have some data element in your data set, but that particular element is not really useful for your questions. So it's just something to keep in mind. The models are not the crystal balls or the silver bullets. The goal of the model is not to forecast the future, but rather it is about learning from the actions that we have taken in the present to sort of triangulate, get a sense of, well, where are we headed in the future and from now on. So that's sort of the take that we have, that David and I are on when it comes to modeling. And lastly, these infectious disease models, they cannot be a replacement for traditional methods. The ultimate goal here is to get a sense of direction of where we're headed, and therefore you have to apply multiple methodology, and modeling is just one part of it. And most oftentimes, this kind of information from the models can be combined with the epidemiology, what we call the epidemiological link in the public health outbreak investigations. And that really does give us a good picture of where we are headed. And for the audience, there is for those in the audience that may be interested in learning about the basics of modeling. Again, we are not designing this to be a didactic lecture, but this article does give a very good introductions to some of the modeling concepts that we will be discussing in this presentation. And this article that was published in Nature actually discusses 4 major principles. Basically, it talks about, in quick summary, it talks about that all these infectious disease models are based on what we call the SIR, or susceptible, infected, and recovered modeling strategies. And when we are describing flow between these 3 states, mathematical states, what it gives it a rise to a value that is called a basic reproductive number. And I'm sure everyone has heard of this word at this point. So this particular word is just basically getting at the number of the secondary cases you can get from one infected case in the population. And then the article further considers what kind of data consideration should be given, like how do you even determine what data elements you need for your modeling strategies. Then again, just in a short nutshell, this article then goes on to details about some of the experiences that these investigators from the UK have undergone, just to talking about how they have selected their model. Are they using deterministic, stochastic? Are they using some form of agent-based modeling, etc.? And basically, of course, depending on the type of model that you do, there are different assumptions that goes with it. And that is actually one of the main points that we want to stress in this particular presentation. So just now quickly going into the some of the project discussions. Like we have mentioned before, we have 2 projects we would like to introduce. This first one was a collaboration between the Center for Health Informatics and the Dr. Pietro Ravani from the Cummings School of Medicine. And really, this is what we call this was really the descriptive analysis. And basically, this study was looking for assessing the impact of public health intervention on the course of outbreak in Alberta, as well as some of the other Canadian provinces. So this was a descriptive study. And what we did for this particular study was that we actually pulled all the policy data that each province has implemented. For Alberta data, the tracker, the CHICSM.ca had all the policy information available for Alberta, so that was relatively easy for us. But for other provinces, we actually had to, many of our team members had to go in and manually abstract some of those data. And for this particular data set, we decided to use the publicly available aggregate number that was available either through the Alberta Health website or other agencies. Now, even though this was a descriptive statistics, we still opted to estimate the basic reproductive number using this R package, EpiEstim. So this particular package has a fair number of some assumptions built into it. One of which is that it assumes a gamma distribution, and you have to know something about the distribution of your serial interval, the mean and the standard deviation. And then it uses the Bayesian inference to estimate the reproductive number in a time-varying sense throughout the epidemic curve. Again, that is a bit wordy. And basically, if you're interested in learning about some of these assumptions, then I would definitely encourage you to go to this link here. And the author's name is Anne Corey. This was a package that was published in 2013. So definitely take a look at that. But then, so the idea for this study was really about take all the descriptive numbers in terms of the descriptive statistics, policy, and compare how that reproductive number have performed. That was really the overarching goal of this particular study. So here is table 1, and this table 1 just shows you basically all the Canadian provinces, their population, the date of their first case detection of the COVID-19 cases, and then the date of the emergency declaration, and then standardized values for total number of tests and total number of individuals that were tested. And actually, if you just look at the emergency declaration role, between all the jurisdictions in Canada, there's not much differences. And when you combine and we actually did another work where we actually abstracted the date of their first policy implementation throughout the healthcare, travel, and there's a few other, like 5 or 6 categories that we're looking at. And basically all these provinces acted around the same time. Now, this table 2 is showing you the outcome data that of the COVID-19 standardized per 100,000 population for the Canadian provinces. And again, you kind of have that, the numbers do vary, and there are some similarities, but that was sort of expected because the population size in each of these provinces were different from each other. Now, when we look at the reproductive number here that was generated, Alberta and British Columbia, for example, have a very similar trend. And it is true. If we go back and look historically back to the behavior of this outbreak, in these two provinces, they're fairly similar. And of course, there are certain provinces that were more active versus not. And here is a example of, so this is actually an Alberta data on how that reproductive, the value have fluctuated throughout the course of outbreak, all the way from March 12th to May 7th. And what we can see here is basically all the policies were implemented between March 12th and somewhere around up until probably the last week of March to early week to the first week of April. And what we're seeing is the that are not is dropping, and it did go down right up until I guess about second week of April when it spiked again. And basically that whole spike is actually related to the outbreaks that happened in the mid-class in the southern Alberta, the Cargill, and those other couple places. So that's what drove it up. And then you can kind of see that it's going down again. And as of May 7th, the reproductive number did drop below below 1, sorry. Now, going back to the earlier mentioning about how the understanding of the assumptions of what goes in to calculate the reproductive number, this figure actually does a fairly interesting job at it. So for this particular figure, this is the Alberta data. So basically, the varying mean of the serial interval, so the various mean and their standard deviations were computed on the exact same Alberta data set. And what we are seeing is the point estimate of the reproductive number actually varies depending on the assumptions that you are putting in. Of course, when you look at something like this, and I mean from our research perspective, the second row, because the range of the confidence interval was the narrowest, that actually was the most reliable estimate in this particular data. But at the same time, this tells us a few things. First, even though the assumptions may be different, the trend is relatively stable, which means this particular data set that we have used is actually fairly compatible with the assumptions of this package. But again, that's sort of the key message. And so when you put all of this information together, in this particular descriptive study, we've definitely identified, yes, some of the control measures did work. Again, was it independent? Was it a combination? That's a little bit hard to tell at this point. But one thing we know is all the provinces have enacted this measure on the same time, and the reproductive number values dropped. So this was a great descriptive study. It gave us a good sense of where we are at. But then the questions that others have begun to ask us, like this particular, for example, estimating the burden of the COVID-19 in the population, like you cannot use this particular study to answer that question because this research study was not designed for that purpose. And that's where David will now can come in and discuss the project number 2 regarding that.
Yeah, thanks, Frank. So I think just to reiterate a few things Frank has said is that this these software packages, these R packages that let you estimate the basic reproductive number are basically based on assumptions like any other model. But these particular packages tend to be, I don't know, what I call model free, in the sense that they don't really let you get or glean any sort of insight into what is possibly happening in the system. And so that's where we thought maybe trying to take that study and then maybe move just a little bit forward, dig a little deeper with creating some really simple transmission models of the spread of COVID-19 in the province. Primarily to try to estimate what I've been calling the burden of COVID-19 in Alberta, but really what we mean by that, or what I'm trying to get at by saying is it's not just the burden, but maybe more the undocumented prevalence of COVID-19 in the province. And from there, that sort of primary goal is that there are several knock-ons that we might be able to sort of get some insight into. And so, of course, one of them is, when did the peak occur? Has it occurred yet? If it has occurred, how big was it? And then from there, we, given that we can probably get an estimate of the prevalence of COVID-19 in the province, how might we estimate some really important sort of other sort of epidemiological parameters? So one of them being the infection fatality rate. Also, something that might be neat to kind of look at is what sort of a hypothesis can a model give us as to how well we're doing as far as testing and catching people who are infectious, which is something called an under-ascertainment ratio. So the way in which that I've gone about this, and actually I did it specifically for this presentation, is I looked at two models, two simpler models. So model one, I'm calling my thesis model. So it's a model that I developed, as you might guess, while I was doing my PhD thesis, to which I had to go back into the archives and basically dust it off. And because I'm sure many people have read about it. But basically what it is a simple sort of compartmental model. Here, the picture that I'm showing you is an SEIR-like model, which basically can be broken up into kind of two subparts, as I call them, which is indicated by these dashed lines. So one is sort of the top part, which is the transmission model, which I'm basically terming our representation of reality. So it's like basically how we think the spread of COVID-19 works in a population. And then there's a second subpart, which I'm calling the surveillance or observation model, which is basically derived on how we observe that. And it's kind of this bottom model that I think are, the bottom submodel that kind of really sets it apart from how people have been modeling this pandemic in particular. And one of the biggest reasons is that it tends to rely on testing data. So this part, if I just go back up for just a quick second, do I have a pointer? Yes, laser pointer, there we go. Okay, so these parts here, actually this part in particular is basically the interface of reality and how I at least assume that we're observing it. And so this takes advantage of a particular time series of data that has been collected by the province. In particular, here is the daily number of people tested right in the province, which is just kind of like this green graph here. But what I do is when I'm integrating this testing assumption is that we have to kind of make assumptions about how well testing is going to work. And it basically says that this sort of mathematical function here, which basically takes testing data as sort of this external variable, something that is exogenous to the model, and then also the state variable of those infectious. And it basically is saying that as we test more and more, we're going to find more cases. And but it also says that as we test more and more, simply doubling the number of tests is not going to double the number of cases that we're bringing in. So it's purposefully working in this law of diminishing returns. And that gives us, if I can, oh, there we go. Yeah, so next, just kind of a sample calculation of how we then can use this. So it's like we take this law of diminishing returns and then we can multiply it by our state variable of those who are infectious to give us those infectious people in the model who are tested. And then using the sensitivity and specificity of the test, we can then get an idea of the infectious people who have been detected. And then basically subtracting that gives us some sort of, from the number of people that are tested, gives us this remainder of people that are tested, which here in this sort of like sample calculation that's shown here would just be the susceptibles tested, which then they then could qualify as false positives given a certain specificity. And then it's this cases, right, this cases submodel, which is our model's representation of the observed cases in the population, to which then gets compared to data. There's a second model that I looked at. Now, of course, why two models, you might ask? I used two models purposefully to try to get some sort of consensus, if any consensus, between using a model to try to reproduce the number of cases, and here a second model, which I call the Oxford model, which I've borrowed from a group out of the University of Oxford, where they are fitting the number of cumulative deaths over time. So we've got two models, both fairly simple. The Oxford model is an SIR structure, but just for those in the audience, I also have looked at an SEIR version of this model, and its results are very, very similar. So I stuck with the simpler version of the model. And so to me, the purpose of using two models was to basically, they're based on different assumptions slightly. So one, back with the thesis model, is that we've got one that is explicitly trying to use how we observe reality, testing in particular, to identify cases. And this one is specifically looking at deaths. And so it takes a simpler approach in that deaths are kind of seen as sort of the end product. And so by abstracting away from that is that the authors of this model basically are assuming that death data is a lot more representative and therefore contains a lot less problems. And so both of these models, as Frank has kind of alluded to, both of them are chock-a-block full of assumptions, many of which could be changed and tested in sensitivity analyses. And so I think it's a good place here for me to say that it's like, these are two models that I've chosen, that I've developed kind of side by side to kind of pit them against one another to see what kind of story we can tell by fitting data, where their small team has actually been doing a giant list search to try to provide people across the country for these models parameter values, so ranges of plausible ranges based on what currently has been published. Thirdly, is how I model basically the province's response to COVID. So like the mitigation strategies and lockdown and the like. And so what I've done is I've used quite a coarsely grained way to do that. And that comes from actually using the Google mobility reports for Alberta, in that for those of you who are familiar with them, there's really no need for me to explain, but for those who are not familiar, basically what Google has done is they've broken up people's mobility, so where they're moving, into 6 different domains. So things like transit hubs, places of work, retail and recreation, and shopping and pharmacy. So there are these various domains which they're tracking people through their phones, which is a little, it's neat and it's a little bit scary all at the same time. But they, so they have these 5 or 6 domains which basically represent fractional changes in people's movement. And so what I've done is, because this is a very sort of coarsely grained population model, I've then averaged them together, except for the amount of time that people have been staying at home. So anything that is outside the house, I've averaged over time to basically represent a fractional decrease in people's movement as an estimate of how they've changed their contact patterns in the population. I've also used the same data because that assumption really says that it's like, that's only based on people's contact. And so also what I've tried to do is I've tried to kind of think of a way to which I also model how well groups of people are basically removing themselves from transmission as well. So it's almost like that there's a fractional decrease in the number of contact, but also that there might be a fractional decrease in, say, the number of susceptible people that are in the population that are actually interacting with others. And in these models, it's actually interacting with infectious people. And so I've used this fractional decline twice. One is in the contact version of transmission, but also to fractionally reduce the number of susceptible people. If that doesn't make sense, I really apologize. I guess showing a formula might have been a lot nicer. Fourthly is that before fitting these models, what I had done is I've used a packaging R called the flexible modeling environment, in which I basically was able to do simple local sensitivity analyses to try to pick parameter subsets that are going to have the most influence on the model, but also that are going to be able to fit the data the best. And so as a result of certain parameters being fit, there are some models that there's some parameters in the model that exist that as you modify one, that the change in that will be offset by another. So it's such that there's collinearity between them. And so some parameters are going to have to be fixed based on well-known values. So one example would be the average infectious period, which according to the Public Health Agency of Canada can range between 2 and up to about 21 days. So fixing them at say 3.8 days, if I recall, is basically what I've been using. But basically with the caveat that it's like, that thing can be a subject for some sort of sensitivity analysis to see that if you fix it at another value, how actually might that affect the model's behavior. And then lastly is that in the thesis model in particular, people who are observed cases are then assumed to be removed from circulation for 14 days as per the Alberta health recommendations. And so this sort of isolation, if you want to call it that, is also assumed to be 100% effective. So those are some assumptions that I think are shared by both models. But then there are some very specific sort of assumptions for each model that I thought that I would try to outline. So the thesis model, as I'd kind of shown previously, directly assimilates provincial testing data into it to drive and constrain certain parts of the model. And so as a result, it's fitting the observed daily cases that we're seeing. And actually one of the, I think one of the biggest assumptions here is that we're assuming that time 0 is here, is when the first case was detected in Alberta, which, as Frank said, was about March 5th. The Oxford model, on the other hand, is based on some sort of fundamental assumptions, at least how it's described by the Oxford group, of that when an infection is introduced into a population, there's a period of time with which it spreads, and that spread is probably undetected. And so here, besides fitting cumulative deaths, the infection here is seeded right over several sort of earlier time points, which I varied sort of incrementally, where, so time 0 is not March 5th in this model. Time 0 goes back in 10-day increments. So 10 days back, 20 days back, 30 days back. I then fit the model to the cumulative deaths, and then based on how well the model fits data, the best fitting model is then assumed to say that's time 0. And so I then use that as time 0 going forward in the simulation results that I see you, or show you, pardon me. Also, lastly, this is a really big one, is that all COVID-19 deaths in the province have been correctly identified. So people have died from COVID, not with. So take that for what you want as well. So fitting the model to data, 2 graphs here. Basically on the left is that we have the daily cases that is fit by the thesis model, where the black dots are basically the data that the province has recorded. And then the red lines represent, for lack of a better word, I guess, a best fit ensemble, meaning that I fit the model to data in kind of a least square sense. I then use that best fitting parameter set to give to a function in FME called mod MCMC, where it's then generating a distribution of best fits or distribution of parameters. And so that's basically what the red lines there are showing. And on the right, it is for the Oxford model fitting the cumulative deaths. And so both models seem to fit really well based on a simple sort of R-squared metric. Importantly, on the right, the Oxford model, I think one thing that was kind of neat is that the best fit model seems to say that at least time zero was somewhere around February 10th or February 15th, which is kind of an interesting hypothesis because it's also something that has been discussed in a few other countries that, you know, it's possible that this infection has actually been around a lot longer than what we have been observing. And I think one thing also that comes out of these is the estimate of the basic reproductive number that both models actually posit. And so the thesis model on the one side says that it's about 4.28, you know, ranging between 4.14 and 4.42, which seems a little bit higher than basically what's talked about all around the world, right? 2 to 3 is the number that you hear. But I think going back to some of the graphs that Frank had shown from the sort of simple descriptive analyses with these R packages that estimate R naught, is that actually depending on the assumptions that you're making about the serial the serial interval, for the same data can actually give you different values of R naught, to which 4.28 is absolutely compatible based on that analysis and here. On the right-hand side, the R naught is approximately 2.92. So something that's a little bit more realistic, sorry, not realistic, pardon me, I misspoke. Something that is a lot more consistently seen, or at least discussed around the world. So that's fine and dandy, like, so what that they can fit the data. Part of the reason that we wanted to do this was, okay, so it's like for these models that can reproduce data, what can they tell us? What kind of hypotheses can they give us about basically what's going on with the underlying burden or the prevalence of the infection in the population? And so while these models are fitting the data, they have to keep track of flows of people between these different states, and therefore have to basically hypothesize about how many people are left in the susceptible state, how many people are in the infectious state, for example. And so what we can do is we can take a peek at, for both models, take a peek at their best guess of what they're saying the prevalence is in the population of Alberta. And so here in one graph, I've got both models, that were the thesis model in red and then the Oxford model in blue, where basically the thesis model posits that around April 26th, there was a peak in the prevalence at about 1.1, 1.2 million cases in the province. Whereas the Oxford model, saying that infection has actually been introduced a lot earlier, says that the peak is around the 16th of April at about 687,000 cases. I think, so back to this kind of consensus thing that I was talking about, is that it seems to say that basically that if we're assuming that the infection was introduced much, much earlier, so almost a month worth, or if it was introduced, the models are able to at least say that sometime in mid to late April, we're pretty sure that the infection peaked. And just something I always kind of like to do is I always, kind of like to anchor basically what these models are saying. And by anchor, I mean, okay, so they're saying one thing, but what have other people said about what might be going on? And so for right now, the only real thing that I have, because we've yet to actually talk to the province about their model, basically what it's shown, and things like that, was that it's like we have that document that this circulated in early April where they made several projections over 3 different scenarios. And so these scenarios largely apply to the thesis model, but basically, so my peak of about the 26th of April of about 1.1, 1.2 million cases seems to kind of fit with, somewhere in between the extreme and the elevated scenario that they had forecast. So it just, it's not necessarily saying that what they said was wrong or that this model is right. It's just trying to kind of ground it in something that someone else has done. So just to make sure that, you know, hopefully I'm not saying things that are too wonky. So from there are some, I think some other sort of critical epidemiological parameters or insights that we can kind of get, right? So this kind of comes back to, sure, that's fine that they fit to data, but what can they tell us about what's going on in the population? And so on the top here, top graph, and then of course the formula for the effective reproductive number, for those of you that know it, is both models are basically saying, so backing up just for a second to the paper that we had written with Pietro, one of the conclusions was that, at least was compatible with the data, was that their time varying R naught has actually dropped below 1 somewhere in about late April, early May, showing that at least that the infection, often when that happens, is RT dropping below 1, is seen as that the infection is under what people call epidemic control. You know, so and these two models that I've used to fit data can also produce something like it. It's not necessarily like a time varying R as those R packages show, but it is something called the effective reproductive numbers. So basically here, it is the basic reproductive number times the fraction of susceptibles that are left in the population. And so in the graph, I've also overlaid two gray squares, one for the Oxford model and one for the thesis model, to kind of show that those models remaining, or sorry, those plots that basically remain flat like that, what that's saying is that this fraction of susceptible people hasn't changed that much. So it's, to me, that's kind of an indication that given that on March 12th, the province basically started these various control measures that they introduced in fairly rapid succession, basically all the way until the end of March, where those sorts of control measures and how I've represented them in the model have shown that at least for the first month, they actually kept this fraction of susceptible people fairly constant, basically meaning that the effective reproductive number was very, very similar to the basic reproductive number. They also suggest that is something that kind of takes the analysis of the first project and kind of adds some context to it. It's these models are at least suggesting that at some point, there's also a law of diminishing returns with these mitigation efforts, or at least my representation of these mitigation efforts, such that they bottom out, they flatten out, and then eventually, because the infection is still spreading, because the mitigation efforts don't completely squash it, it just takes the infection just a little bit of time to work its way through the population, and slowly but surely it starts to kind of take away people who are susceptible, and then this fraction then actually begins to decrease. And so these curves then actually drop, and they drop below 1 somewhere around, for the Oxford model is about late April, and then for the thesis model, which is about early, well actually even late April as well, perhaps early May. And so it's showing that that one, the previous analysis and this analysis are at least congruent, I guess, in a little bit, but they have, but these two models add just a bit of context to that. So it's a combination of that, yes, mitigation efforts worked, but at some point they kind of became overwhelmed, and that's maybe not quite the word, that, but it's just that the infection was able to kind of reach a large enough fraction of susceptibles that it was able to take off a bit, and thus led to the peak. From there, the other knock-ons here is this table down here, where it's like we're able to get some estimates of things that people find somewhat important, especially when it comes to a novel respiratory pathogen. So one is the infection fatality rates. So where both the thesis model and the Oxford model are basically saying that the infection fatality rate is quite low, almost an order of magnitude lower than some of the other estimates that are seen around the world. But I think actually down here, one of the things that actually really caught my attention was that the thesis model also allowed me to get an understanding of this under ascertainment. And so because I'm explicitly looking at people that are caught and people that are not, versus people that are not would be these undocumented infections, is that you can then get your ratio. And for anybody who's been following some of the serological studies, like the earlier serological studies that are coming out, is that one in particular that has caught my eye is one that was done down in Santa Clara County in California, where they did a serological survey of the residents of Santa Clara and found that based on the number of observed cases and the number of cases that, or people that are testing positive for antibodies, are showing that that the number of people that are testing positive for antibody can be anywhere from 50 to 80 times greater than those that we've been observing. And I think something that's neat, now I know it's not exactly the same because they're actually looking at antibody, but it's like something that the model is actually able to spit out, says that right approximately it's 73 times higher, but then can range between 65 to 82. Now, but that's a median value, so that's over the entire sort of period of the outbreak. This can be time varying as well, which can actually get up into the range of the thousands, basically meaning that the infection can spread faster than we can catch it. So some of the lessons that we have learned, I guess, so this is just me wrapping up quickly, obviously. So at least qualitatively, study one and this sort of simple modeling study is showing that at least in early May, it seems that the reproductive number, whether that be a time varying RT or even the effective reproductive number, seems to be below 1. And so the models that I had done actually compared to the model free both indicate that there was this effect that kind of was brought on by mitigation strategies. The models kind of suggest something that is part of that, but it's also kind of over and above. So it's like there were these mitigation strategies that were working, but at some point it's just that the infection kind of made its way through the population. Now this, I should say, these are models. So it's I think one of the biggest cruxes or limitations of these models that I think is not necessarily their simplicity, but I think what it is my representation of how these sort of mitigation control strategies work. And so more detailed models, I don't know if anyone's familiar with the work of Mark Lawrenson, who's a PhD student. He has a far more detailed model where he actually is able to look at many different contact strategies. So like different, it's like this heterogeneous contact of people in the population, given age, and also certain types of contact that is maybe a little more conducive to the Google data. So it's something that should be taken with a grain of salt, but that the results are compatible with data. So that means that they actually create or have a hypothesis that can be tested with further study. And that's kind of the whole main point of science, in my opinion. So what does this mean for a second wave? That's always tough, because these models that I've shown you today are basically models of up until now, like where are we? And so as Frank said, these models aren't necessarily crystal balls. So forecasting forward in time can be really neat. But often what you're doing is, when you're fitting these models to data, is that you're kind of assuming things that in the past are going to be important in the future. And so forecasting a second wave, I think, becomes difficult. However, if these models that we've shown, if they're actually going to have like any sort of ability, it shows that it may be unlikely, but that's but it's just that time will tell. new data. These models could absolutely change with new data right coming in. I think also what something we're going to try to do coming back to this, some of the assumptions of the model is actually Mark Lawrenson and I have been talking about trying to find this modeling middle ground, because basically the models that Mark has been using for his PhD and then some of the models that I've been using here are kind of saying different things about what's going on in the population. So I think one of the most important things, and this actually was Mark's suggestion, was a really good idea, is basically to try to bring the models together into some sort of middle ground. How, sort of how might I make my models more like his, and how might he make his models more like mine, to try to maybe get sort of like a general consensus to kind of zero in on something that might be a lot more plausible. And of course, as I said, lastly, is that the results of these models provide hypotheses that can be tested by further study. So it's very possible that they could be wrong, but it also highlights, and this is something that has been discussed in the UK going all the way back to February and March, is that there's a need for population level studies. So for example, seroprevalence studies, to try to at least get a lower bound estimate on what is the actual prevalence in the population. Now, seroprevalence studies are always tricky, because right about now, most people would probably agree that the lab methods to actually detect antibodies are not very good. Also, they should come with the caveat is that not everybody who's been infected is going to produce antibody. So so that's why I say that they're probably going to provide a lower bound, but these sorts of larger population-based studies are needed. And so that's basically it. And of course, tapping back into our zombie apocalypse, we have Sean and his buddy playing video games while they're riding things out. One a zombie, one not. Anyway, that's it.
Wonderful job. I'll clap for the group here. Thank you so much, Frank and David, for the wonderful, thorough presentation. You really brought to light how the models are made, what they're useful for, and the impact that they can have during these uncertain times. I think we can all appreciate the hard work and all the complexities of these types of projects.
For more information on who we are and what we offer, visit our website at coming.ucalgary.ca/CHI. If you are interested in our services, collaborating with our team, or have any other inquiries, contact us via email at chi@ucalgary.ca.